Good day. The talk for today will be on the state of the pacing, SOPA, how we are doing in delivering pacemakers, ICDs, and RF ablations to Filipinos. And for the next 25 minutes or so, we will be discussing or assessing where we are in delivering standard of care pacemakers, ICDs, and RF ablation therapy in the Philippines. We will be summarizing what the PHRS has done to bridge these gaps and answering the following questions. What is the burden of disease of symptomatic bradycardia, ventricular arrhythmias at risk for sudden death, and supraventricular tachycardias or SVTs? What is the utilization of pacemakers, ICDs, and RF ablation in the Philippines? What is the cost effectiveness of the above procedures? And what is the impact on the budget? So in 2021, in the middle of the pandemic, here is where we stand. The Philippines has a population of 108 million, 135 hospital beds per 100,000 population. There is roughly a little more than one physician per 100,000 people. Our GDP stands at 276 billion US dollars, and the Philhealth coverage, while wide at 93%, is matched with a fairly smallish healthcare expenditure of 4.1%. Our Human Development Index, or HDI, puts us at 106 among all countries in the world. So now let's focus a little bit on the three therapies to be studied. A pacemaker, as most of you probably know, is a permanently implanted device. It is put under the skin, connected to 1, 2, or 3 wires, which are positioned in the heart. It is used for irreversible symptomatic bradycardia, for which there is no satisfactory medical alternative. Its battery lasts for around 10 years, and it stimulates the heart on demand. Now, in contradistinction, the implantable cardioverter defibrillator, or ICD, is likewise a permanently implanted device under the skin, which, like a pacemaker, is connected to 1, 2, or 3 wires, which are strategically positioned in the heart. It works for patients by terminating ventricular tachycardia by either pace termination or delivering a shock, and it is life-saving for this subset of patients. Radiofrequency ablation is a catheter-based procedure. One of its more important uses is for the management of supraventricular tachycardia, or SVTs. It is now considered first-line therapy based on international practice guidelines for SVT because of a very high success rate of 90 to 95% with an acceptable complication risk of around 2 to 3%. In this procedure, a catheter is inserted through the veins into the heart and is used to map and burn or ablate the focus of the arrhythmia. Now let's turn to the first two questions that we wanted to answer, which are basically the prevalence or burden of disease and the utilization of the therapies for these diseases. So what is the current per capita implantation rates around the region? So you will see in the map is shown Southeast Asia with the different countries. And looking at the per capita pacemaker implantation rates will show a wide range of values, as high as 178 in Singapore, which is almost comparable to the 228 in Taiwan. Now, at the other end of the spectrum is Indonesia. Indonesia has a very big population, and so the per capita pacemaker implantation rate is 6. In the middle are Thailand with 54, Malaysia with 24. Now, the Philippines has much work to do as we only have 12 per capita utilization of pacemakers. And if we compare ourselves to Vietnam, which has roughly the same population size, Vietnam has done quite well with 50. So what then are the strategies formulated by the Philippine Heart Rhythm Society? We noted from experience that when the government started subsidizing or paying for half the pacemaker expenses, their volume of pacemaker implantation rates quadrupled. And so our first strategy is to try to get government subsidy for device implantations and RF ablations. This is akin to what is already being done now for coronary artery bypass grafting or CABG, where the government pays on the average 550,000 pesos for qualified cases. So this is called a special benefit program. And in order for the Philhealth and the Department of Health to consider our proposal, we need to establish local data on the burden of disease, and second, on the cost effectiveness of the above proposed therapies. We partnered then with the clinical epidemiology group in order to answer the first two questions on prevalences. The group has an experience of publishing Philhealth prevalences for heart failure in 2018. And so we partnered with them and with the following goals in mind. First is to determine the burden of disease based on Philhealth claims from 2017 and 2018 based on ICD-10 codes. The second objective was to determine the number of claims for pacemakers, ICDs, and RF ablation, this time based on RVS codes for the years 2017 and 2018. Third objective was to determine any regional differences in both the burden of disease and the claims for the above procedures. And finally, as an extra, we were able to have an insight on the crude mortality rates for the specific diagnosis. Now, this is the data table for symptomatic bradycardia. So you will see reflected are the different ICD codes, their respective diagnosis of sick sinus syndrome, AV block, and so forth down the line, and the crude numbers for 2017 and 2018. So adding up the individual diagnosis yielded a crude number of 958 diagnoses for 2017 and 1,144 diagnoses for 2018. As a reference, Vietnam has around 4,000 patients that received a pacemaker in around the same time period. Now, another piece of information that may be gleaned from this table are the relative crude mortality figures. So one will see that if you focus on sick sinus syndrome, the crude mortality rate is quite low, 0.2 in 2017 and 0.3 in 2018. But focus on AV block, third-degree AV block, which carries with it a considerable crude mortality rate of 3.7% in 2017 and 3.6% in 2018. The next data table shows that for ventricular arrhythmias, that puts the patient at risk for sudden death and may possibly require ICD implantation. So again, in the table are reflected the specific ICD codes, their respective diagnoses, and the number of patients that had claims for those specific ICD codes in 2017 and 2018, with respective totals of 1,284 for 2017 and 1,480 for 2018. Now, because of the serious nature of ventricular arrhythmias, one is not surprised to see the very high mortality rates ranging from 16% for re-entrant ventricular arrhythmias to as high as 25%, and for ventricular fibrillation, 27% and 23%. For supraventricular tachycardias, or SVTs, there were 1,121 claims made in 2017 and 1,149 in 2018. Now, one will note that the number of claims for the specific diagnosis ranges in the area of 1,000 per diagnosis. How do these claims for specific arrhythmia diagnosis translate into claims for procedures? So here we have in this table the three therapies. For bradycardia, it's pacemakers. For sudden death, ventricular arrhythmias, it is ICDs. And for SVT, RF ablation. And we have the 2 years, 2017 and 2018. We reported earlier the specific number of claims for each of the diagnoses for the 2 years. Note furthermore that the actual number of claims for procedures is even lower. So for among the 958 patients that needed pacemakers in 2017, only 549 got it. In 2018, 683 out of 1,144. And the utilization rate is even lower for ICTs. Only 50 claimed Philhealth benefits for ICT implantation out of 1,284 that needed it in 2017. And 4 out of 1,480 in 2018. Now, for RF ablation, the figures are equally low. 25 out of 1,121 claimed radiofrequency ablation in 2017, and only 19 out of 1,149 claimed for RF ablation in 2018. Looking across the different regions of the Philippines, one can note the distribution of the numbers, and it is not surprising that the highest number is from the National Capital Region. Now, trailing behind are Regions 1, Region 3, Regions 5 and 6, 6 and 7 rather, and Regions 10 and 12. The other regions have even lower numbers. Now, this is the study group that conducted the prevalence studies. It is composed of the Clinical Epidemiology Group in partnership with the Philippine Heart Rhythm Society. Let's turn to the third and fourth questions raised at the start of this talk. And those are the cost effectiveness data and the cost utility data. And to answer these questions, we partnered with the Alliance for Improving Health Outcomes, or IHO, in conducting a cost utility analysis of dual chamber pacemaker implantation versus optimal pharmacologic therapy for symptomatic bradycardia due to sinus node dysfunction in AV block in adult Filipinos. We likewise partnered with them as they spearheaded the conduct of a cost utility analysis of radiofrequency catheter ablation versus optimal pharmacological therapy for supraventricular tachycardia in adult Filipino patients. And for the methods for both models, we calculated incremental cost per quality adjusted life year, or QALY, gained. And this allowed us to calculate for the so-called ICER, the incremental cost efficiency ratio, which is the benchmark for determining cost effectiveness. And we check this for both pacemaker, comparing to optimal medical therapy, and radiofrequency ablation versus optimal medical therapy. Now, the utilities for the entry states were derived from patient interviews, actual patient interviews, using a validated and widely accepted assessment tool, while the utilities for the other health states were taken from published literature. Costs were assessed from the healthcare payer perspective and included direct medical expenses for pacemaker devices and insertion costs, maintenance drugs for the pacemaker devices, and the likelihood and costs of possible complications requiring hospital admission. Deterministic sensitivity analyses were done to evaluate responsiveness of the results to changes in device costs, replacement incidence, and discount rates. The results were taken from this MARKOV model. So in this MARKOV model, for optimal medical therapy, 4 states have been defined and validated by content experts from the Philippine Heart Rhythm Society. The states between which the patient can transfer are the treated stable state, syncope, and sudden cardiac death. And there can be transition among the 3 states. But the 4th state, which is death, is the only exit from this model. Now, the MARKOV model, on the other hand, for permanent pacemaker, adds to the 4 states previously discussed a state of post-pacemaker implantation complication. So having received the pacemaker, there is the possibility of having complications and moving back to a stable state. And then the patient can likewise move from being treated to developing syncope because there is still a small risk of it, but smaller. Sudden cardiac death, and death being the only exit from this MARKOV model. Now, for radiofrequency ablation, there are more states that have been defined and validated by content experts from the Philippine Heart Rhythm Society. So for the optimal medical therapy arm, there is the stable state, there is a state of SVT recurrence, there is a state of adverse drug reactions from the medical therapy, there are dropouts, and there is the state of death. Compared to the ablation arm, where aside from the states previously mentioned, there is the state of developing complications from the radiofrequency ablation, a state of requiring repeat ablations, and then, of course, death is again the end or the exit from this model. Now, what are the key findings based on the cost-utility analysis? And here I will ask you to focus on the second row, which shows the discounted costs and QALYs over the patient's lifetime. So this is for a model of 1,000 patients, and one will see that per patient, the cost over a lifetime of having pacemakers implanted is roughly 1 million pesos, compared to a cost of optimal medical therapy over a lifetime of 526,000 pesos. Now, as far as the QALYs gained, having a pacemaker yields a QALY or good quality added years per patient to 7,473 compared to optimal medical therapy with 4,523. Now, if you take the difference between the cost, the incremental cost will be 527,000 comparing pacemakers to optimal medical therapy, whereas the incremental cost effectiveness is 2,949. And if you take the quotient or the ratio of these two numbers, it yields an ICER or an incremental cost effectiveness ratio of 178,000 pesos per QALY gained. So just keep that in mind as we go through the similar table for radiofrequency ablation. So here, the cost per patient for ablation over a lifetime is 338,000 pesos. The cost of medical therapy over a lifetime is 76,000 pesos, yielding an incremental cost of 261,000. Now, the QALYs gained by doing an ablation is 8,061, comparing to 5,705 QALYs for optimal medical therapy. And so the ratio of the two yields an ICER of 110,000 pesos. Now, what to do with all these numbers? one then needs to more or less make a judgment on what the cost effectiveness threshold is, meaning what is the cutoff ICER which is considered to be cost effective. And the World Health Organization has recommended this empiric cutoff of 1 to 3 times the per capita GDP, which would in the Philippines translate to 174,000 pesos to 522,000 pesos. However, there has been some discussion in the literature that in countries with low health development indices, and the Philippines might be one of them, that a threshold of 1 to 2 times GDP might be more appropriate. So because the calculated figures of 178,000 and 110,000 are considered to be the base case rates or the point estimates, further sensitivity analyses were conducted by constructing this so-called cost effectiveness acceptability curve. And basically what it is that the same Markov model was run 100,000 times more with different iterations inputted for the variables to come up with these curves for PPI in red and optimal medical therapy in blue. And the point where the two curves cross is where the cost of ablation becomes equal, where the cost acceptability for ablation equals the cost acceptability for optimal medical therapy. And so that cutoff, which was found here to be around 300,000 pesos, is one other index that might be used to determine cost acceptability, meaning at values greater than 300,000 pesos, the cost acceptability for PPI or permanent pacemaker now becomes greater than the cost acceptability for optimal medical therapy. Now, similarly, for radiofrequency ablation, the same construction of cost effectiveness acceptability was done by running the model 100,000 times with varying iterations. And the points where the two curves cross were determined to be in the 370,000 peso area, with values above it showing the values where the cost acceptability for RF ablation then exceeded the cost acceptability for optimal medical therapy. Note that both 300,000 pesos for PPI and 370,000 for RF ablation are still well within the 2 times GDP recommended by the World Health Organization. Now, taking one final look at the threshold, because thresholds can sometimes be arbitrary and may not necessarily reflect the social reality in the country. So one recommended way of deciding or making a judgment on this is to determine what is to be given up. What impact does it have on the budget of the country? Will it take away from other simpler, more essential therapies, or will it actually be value added? And to answer this question, we present the results of the budget impact analysis conducted by the IHO, again in cooperation with the Philippine Heart Rhythm Society. And these are the key findings of the budget impact analysis. First is that over a 6-year horizon, full subsidy of pacemakers would result in a 5.6 billion cost savings. And that is broken down into 1.8 billion for sick sinus syndrome or sinus node dysfunction and 3.8 billion for AV block. Note that the bulk of expenses for permanent pacemaker was in the first year, whereas for optimal medical therapy, there was consistently high expense over the lifetime of the patient, consisting mainly of hospitalization for syncope. Let's study the data, the budget impact data further. So in orange is the total cost for medical therapy. And you will see that comparing to all other combinations or all other arrangements with permanent pacemaker implantation, medical therapy ultimately costs more. It is almost 6 billion more expensive than subsidizing 100% of the population and covering 100% of the costs. But what if we took the example of Vietnam, where the government pays for 50% of the cost of the pacemakers? Then that would put us here. It would cost somewhere around 12 million pesos, resulting in a cost savings of 14 million pesos. So the sensitivity analysis provides, the budget impact analysis provides variations in the coverage and allows us to compute the cost savings for the government depending on the choice. Now, this final graph shows that on the x-axis is the percent of the population covered and the cost on the y-axis. One will note that the bigger the proportion of population covered, the lower is the cost. If you cover only 10%, then the cost rises. So based on this, the best approach would be to cover all of the population and just decide what percentage of the package the government is able to pay for. So, ladies and gentlemen, doctors, the key points from this lecture are, first, that there is certainly a need to improve pickup rate and access to simple healthcare procedures such as pacemakers, for which there is no alternative medical therapy. Second key point is that pacemakers, ICDs, and RF ablation may be costly at the outset, but cost-effective and cost-saving in the long run. It will save the country 5.7 billion Philippine pesos in 6 years, considering 100% subsidy, or even as big as 14 billion pesos if only 50% subsidy is given. So it is best, I think, based on all the analyses conducted, to cover 100% of the population and subsidize at least 50% of the cost per procedure. And so I'd like to acknowledge for this second half of the lecture, the IHO study group led by Dr. Miharu Kimwell, who has patiently coached me on this presentation, and the Philippine Heart Rhythm Society board, which has participated in the conduct of this study. And I end with this quote from Kit Rocha. This is actually a pseudonym for a couple of authors, but they have said that, but everything is a cost-benefit analysis, isn't it? Do I want this badly enough to pay the price? Thank you very much, and please stay safe.